It's my pleasure to introduce the next speaker. We are lucky to have Dr. Kara Wyant here talking about managing medication for better health outcomes. I think many of you have met Dr. Wyant before. She's a movement disorder specialist. She received her medical degree from University of Toledo. She completed her neurology residency training at University of Pittsburgh Medical Center, where she was chief resident for her last year. She did her fellowship for movement disorders at the University of Michigan. She serves on the neurohospitalist service at the University Hospital in Ann Arbor and also is involved in teleneurology consults for Mid-Michigan Health. I think a lot of you realize that a lot of neurology in the future in many parts of the country is going to be done by computer, and teleneurology is a very, very important thing in the future of medicine. It will allow specialists to see patients remotely, either at hospitals in various parts of the country or in their homes. Dr. Wyant sees patients in Ann Arbor and will be seeing patients in Midland through Mid-Michigan Health. She's going to talk about managing medications, and I welcome her.
Thank you very much. So I'm very excited to be here today to be able to kind of talk to you about everything from the nitty-gritty basics of the medications we use to treat Parkinson's disease to the course of Parkinson's disease, how it evolves, and how we need to adjust our medications and our goal of therapies as we go through the disease in order to improve the health outcomes in our patients. All right. So first, we're going to start by just laying out the basics. What are the medications that we use to treat Parkinson's disease? How do they work? Are there interactions you should be aware of? Discuss best practices then for timing and why that's important. So kind of going back to some of the questions that were asked in the last session, reviewing how symptoms change with Parkinson's disease and how we may need to shift our focus, and also just a reminder about medications that can worsen Parkinson's disease so that we're aware when we're giving patients their medications. So just a very, very brief reminder. So when we look at Parkinson's disease and making the diagnosis of Parkinson's disease, you have to have Parkinsonism, and that's the motor symptoms of Parkinson's disease. So that is specifically bradykinesia, or that slowness and smallness of movement, and that has to be there. You cannot have Parkinsonism without it. And then, in addition, a resting tremor and/or rigidity. Now, Parkinson's disease, as you know, these patients have many more symptoms than just stiffness, slowness, and tremor. They have all kinds of non-motor symptoms that can affect their thinking, can affect their mood, can even cause hallucinations, can cause their autonomic nervous system, that's their automatic nervous system, so the one that controls your heart rate, your blood pressure, your gut movement, can cause problems with all of those functions as well. So when we talk about managing the motor symptoms of Parkinson's disease, that's the stiffness, the slowness of movement, and the tremor, we're talking about, that is the basics of our treatments for Parkinson's disease right now. These other non-motor symptoms, they do have treatments, but it's on a case-by-case basis. And the medications that we use for Parkinson's disease won't treat these non-motor symptoms, okay? So it's important to make sure you know what you're treating with these medications. Currently, there are no therapies available to reverse or slow the disease progression of Parkinson's disease, okay? So that's also important to recognize, because it's important to decide when are we going to start medications. We don't have to start it as soon as we see something that might look like Parkinson's disease. We start it when the symptoms become bothersome, because these are only symptomatic therapies. So the goal with our management when we're talking about these motor symptoms is to reduce the severity of their symptoms and to maintain their independence. So, and again, we're focusing on motor symptoms first. So the types of medications that are available to treat Parkinson's disease motor symptoms are those specifically that work on that dopamine system. So as you heard, Parkinson's disease is caused by that loss of the dopamine-producing cell. So what we want to do is give back dopamine. So we have dopamine replacement therapies, with the hallmark being the carbidopa, levodopa, or Symptomatic. Then you have dopamine agonists. Those are ones that work directly on that receptor that is activated by the levodopa. Then you have extending agents. So these are drugs that decrease the breakdown of dopamine, so it allows that levodopa to stay around longer, to be more effective, and to last longer. And then you have a couple other ones that we'll touch on just briefly. So dopamine replacement. So going way back in the 1950s is when neuroscientists started to figure out where are neurotransmitters in the brain and really define where are they active and which places of the brain are which neurotransmitters. And then it was in about 1960 where they defined that in patients with Parkinson's disease, there was decreased dopamine in the striatum, that's a part of the basal ganglia. And then it was in 1961 when the first person reported that they gave a patient IV levodopa, and their akinesia, their stiffness and slowness and inability to move got dramatically better. And then it was over the course of that next 10 years where levodopa went through clinical trials and then finally was approved by the FDA in 1970. So when we're talking about dopamine replacement, that's synonymous with Symptomatic. There are multiple different doses of this medication. The 25-100 is the most common one that you'll probably see prescribed. That first number is the dose of the carbidopa, and that's the one that the carbidopa is a medication that keeps the levodopa from being broken down in the stomach so that it can get into the brain and be active and broken down into dopamine and be used. So in patients who have a lower dose of carbidopa, they may have more side effects. They may have more nausea and vomiting because that levodopa may be being broken down in their stomach. So we try to avoid the 10-100s and use at least the 25-100s. There are also controlled release Symptomatics available, a formula of extended release Symptomatic or Rytary available, and as well as an intestinal infusion gel called Duopa that can be given through a treatment tube that's a PEG-J procedure. So as you can see, each one of these different medications has a different dose to them, okay, which can be very confusing. And it's also a very important reason why you have to make sure you know which medication is on the patient's medication list, because these are not one-to-one conversions from one medication to another. So the controlled release carbidopa levodopa is not really long-acting. So sometimes we'll kind of, myself included, will step back and say, oh, it's just long-acting Symptomatic. It's not long-acting Symptomatic. It's delayed release. So instead of taking the typical 30 to 60 minutes to take effect, it takes anywhere from an hour to 2 hours to take effect. And as the disease progresses, that effect may become more variable in how long it can take, and some doses may not even work at all. Then because it's delayed in onset, it'll last, again, that extra 1 to 2 hours compared to the immediate release. So it is not really extended release, just delayed release. This medication can be used in combination with the immediate release as well as alone. So where I use this more commonly is in my patients who are kind of new to levodopa and they're having kind of peak dose side effects because that immediate release gets into their system too fast. They get a lot of nausea. They might get like super fatigued 30 minutes after their dose. I might try switching them to a carbidopa levodopa, the controlled release or that delayed release formula, because that won't peak quite as high. So they're able to tolerate it better. The other time that this is effective is as patients are progressing in their disease and overnight their symptoms kind of get worse, and so in early morning hours they develop dystonia or abnormal muscle contractions, twisting and pulling movements in their legs that can be painful. So giving them a dose of this at bedtime can extend their on time overnight so that they're not wearing off and getting off dystonia before their morning doses. So the extended release of carbidopa, levodopa, or Rytary has been approved for patients who have motor fluctuations. So as we'll talk about this, but as the disease progresses, patients need more medications, more frequent dosing. When patients are requiring 4 to 5 times a day of the levodopa in order to make sure that they're getting enough, often it's easier to switch them to a medication that is longer acting, and that's the Rytary. So that way they only have to take their medications 3 times a day. So this in studies has been shown to decrease the off time by 1.2 hours a day compared to the regular Symptomatic. Unfortunately, this is still a relatively newer drug, so it is fairly expensive, and there are patient assistance programs out there, but can be unwieldy for just the patient by themselves to do. So you might have to involve your social worker or office staff in order to get this approved. So when we're talking about dosing of these medications, so for the immediate release, and even sometimes the controlled release when you're starting it alone in monotherapy, it's a 3 times a day pill, okay? It will not last the full, you cannot do twice a day, it will not last that long. You need 3 times a day dosing based upon the pharmacokinetics. It is a symptomatic management, okay? So we want to give it to patients when they're awake and they're moving around, because this is to help them get up and move around. It's not going to be as effective if you give it at bedtime unless they really have bothersome tremors while they're falling asleep or other off symptoms overnight. So typically when we start, we dose this before breakfast, lunch, and dinner time. When patients have a very high protein diet, you need to separate it from meals. At least 30 minutes, best would be 60 minutes in order to make sure that it's going to all be broken down and absorbed. As the disease progresses, you're going to need more and more of this. And I always make sure I tell my patients right away as we're going, there's no maximum dose, there's no minimum dose, everybody is different. And as the disease progresses, it's not that the effect wears off, it's that the disease progresses. You continue to lose those dopamine-producing cells, so you're just needing more and more of this. So it goes back to the Herald that timing is everything on these medications. For each patient, it's going to be individual for how long that dose is going to last. Some of our patients can get a good effect for a full 6 hours. Other ones 5, others 2. So everybody has a little bit different timing and how frequently they need to take their medications in order to be able to get up and move around, to have control of those motor symptoms. So common side effects of any of these preparations: nausea, fatigue, orthostatic hypotension, that's that lightheadedness and dizziness you get as you're standing up. These are common starting dose medication symptoms that I will review with my patients. Later in the disease, as we're talking about increasing doses because they're having more fluctuations and other problems, I always make sure to remind them that these medications may cause confusion or some foggy thinking, hallucinations, and can contribute to levodopa-induced dyskinesias. Okay, so it's very important to make sure that you understand that these are potential side effects, especially as the disease progresses. And one of the best things about this medication there are no interactions. So you don't have to worry about dosing this based upon renal function, liver function, what other medications that they are on. This is a great medication. So that next group of medications. So if I can't just give you back dopamine, then I'm going to just stimulate that receptor so that it turns on and it works. And those are called our dopamine agonists. And we have the 3 main ones, which are pramipexole, ropinirole, and rotigotine. Rotigotine is newer. It's a patch. It's just a 1-time-a-day dosing. The pramipexole and the ropinirole also have long-acting formulas. Those are also new, so they're a little bit also more pricey. There is a very short-acting, very fast-acting form of a dopamine agonist called apomorphine or apokin. This is a sub-Q injection, and we'll talk about this in a little bit when we talk about rescue therapies. So for the dopamine agonists, these treat motor symptoms like the Symptomatic does. You can also add it on to someone who's having motor fluctuations with their levodopa. So over time, our practice and what medication we start has shifted. So initially, like I gave you that history, carbidopa, levodopa, that was our mainstay, that was what we had. When we started getting these other drugs and we started looking for ways that we can delay these motor complications, the motor fluctuations, the dyskinesias, because they were very bothersome to patients. And so that was where this class of medications came from. So they've done studies and shown that in patients who are started on these medications compared to carbidopa, levodopa, they don't have the dyskinesias as early and sometimes can delay that by several years. However, as we follow these patients over time, what we do notice is that they have more side effects. They also can have some newer side effects that we didn't know about called impulse control disorders, have some bad reactions when you withdraw the medication, and they are just not quite as wieldy, have a little bit more confusion, a little bit more cognitive issues as the disease progresses, a little bit more orthostatic hypotension. They also have more sleep issues and can cause sleep attacks, so where someone is just talking to you and then all of a sudden they just fall asleep. Can be very dangerous, especially if you decide to start these in a younger person with Parkinson's disease who is still working or driving. So I'm going to touch briefly on these impulse control disorders because this is a very important thing to recognize in our patients who are on dopamine replacement therapy, specifically dopamine agonists, so that way you can screen your patients or identify, why are they doing that odd behavior over and over? Maybe it's their medication. So impulse control disorders. So this is defined as the failure to resist the impulse or drive or temptation to perform an act that is harmful to oneself or to others. So even though I know I shouldn't be going on that website, I just keep doing it. I can't stop myself from doing it. The typical examples that are in the literature are pathologic gambling, shopping, hypersexuality, and binge eating. So you can see why patients might not just offer this information to you, but it's important to ask them when they're on these medications. They occur in patients with Parkinson's disease who are on dopamine replacement therapy. They are much more common in patients who are on dopamine agonists than levodopa, but they have been described in even amantadine and some of the other MAOB inhibitors. They can be reported, so the larger study shows that maybe probably about 17% of patients will have these impulse control disorders, so that's a pretty high percentage. But there are some other smaller studies that suggest it can be even as high as 40%. Risk factors for this are, that first one I want to point out, younger age. So when we're trying to decide which medication to start, be very wary when you're considering treatment of a younger patient. So there are other related issues that also fall into this category, things like punding, it's just repetitive, purposeless movements that people will do. I think the biggest example that sticks in my mind was from residency when we were at the VA, and a patient had to come in for treatment in order to withdraw this medication because he couldn't stop scrubbing his floors to the point that his knees were open, had non-healing wounds, his hands had sores and everything because he just couldn't stop himself from doing something even though he knew it was harmful to him. Hobbyism, so you'll hear people collecting very odd and random things. That is something to recognize. This falls within those impulse control disorders. This is iatrogenic. We are causing this by the drugs. Hoarding, walkabouts, or a couple other examples. So the treatment of these is a little tricky. We try to decrease the levodopa or the dopamine agonists and get off the dopamine agonists as quickly as we can to do this. That's not always easy. So as the disease progresses, people need more and more medications. So as you're decreasing the dose, they may not be able to move around. They may no longer have the control of the tremor that they need. They may have more balance problems because they can't move around as easily. So it's a tricky situation. There is one study that showed that amantadine reduced the symptoms of pathologic gambling in a patient with impulse control issues. However, this needs to be replicated. It's not clear that this would necessarily work for other impulse control issues. Cognitive behavioral therapy has a couple people who are proponents of this, but really it's trying to adjust the levodopa. So one of the other ways that we try to change the levodopa is by giving them a continuous infusion or getting something like DBS surgery that allows us to decrease the dose but give them a constant stimulation such that they're still able to move around and don't have the worsening of their motor function. So just briefly, dopamine agonists also have this withdrawal syndrome that can develop. And these are physical and psychiatric symptoms that cause as you're tapering the medication. And it doesn't matter how fast you taper the medication, you can be going down super slow and they can still develop these symptoms. It occurs in 1 in 5 of the patients that are on these medications, and it's very under-recognized. So risk factors for this, if patients have impulse control disorders, they're unfortunately much more likely to have dopamine agonist withdrawal symptoms. And patients who are on higher doses of these medications are also more at risk. The symptoms that patients may complain to you about, so say they're having more confusion, and they're starting to hallucinate, we need to decide to pull them off of their dopamine agonist. So I give them a relatively reasonable taper. We're only going to go down by 0.25 milligrams once every 2 weeks. So we're going to go very slowly so that they can come off their medication. They call your office 3 days later. they're anxious, they're agitated, the wife calls because they're having panic attacks, they've already had to go to the emergency department once, and already he's short of breath again. They're very flushed and diaphoretic. They can't sleep, and they're just having pain all over. And this is not something that they've had before. There haven't been any other adjustments in their medications, just this small decrease in their medications. It can be that exquisite. The treatment is just to increase the dose of the dopamine agonist back to where it was. None of the other ways that we manage these kind of physiologic and psychologic dependence really work very well. Even sometimes increasing the levodopa is not as effective. They really need that dopamine agonist. So as you can see, dopamine agonists have downsides, and it's important to be aware of the downsides when you are determining what's the best treatment, or when we have to decide how do we adjust and how do we get this person off of this drug, and what do I watch for. So moving on to that third category of dopamine extending agents. So these medications will decrease the breakdown of dopamine in the brain. So if you look on the left side of the PowerPoint, so you can see this chemistry equation here where levodopa is broken down into dopamine, and this is what's active in your brain. And then you have two different mechanisms by which it is broken down further and gotten rid of. And those are through COMT and MAOB. So if we block those enzymes that want to break down dopamine, dopamine will last longer. So therefore, your doses of levodopa will be more effective and last longer. That's kind of the thought process behind these medications. So entacapone is the most common COMT inhibitor used now. The other one that was on the market has been removed due to other issues with organs. So this medication has been shown to decrease off time by about 1 1/3 hours a day. So that's pretty good. Side effects of this medication is because it causes the levodopa to be around longer and be more effective, you could have more side effects from the Symptomatic. So you could have worsening orthostatic hypotension, you could have more levodopa-induced dyskinesias. So a lot of times when you start this drug, you also have to decrease the dose of the levodopa. Other things that are just from this medication: abdominal pain, nausea, diarrhea, and then it turns your body fluids orange. And it's not toxic, it is just a normal chemical reaction from this medication, but it's important to warn your patients about so they don't just abruptly stop it because they're concerned. So interactions of this drug. So what it does is it does interact with a couple of our more common medications. One of them is a PD medication, apomorphine. So what it does is it enhances the effect of apomorphine. And we'll talk about that in a little bit, but apomorphine is one of those dopamine agonists that has a lot of extra orthostatic hypotension and nausea associated with it. So if you're enhancing the effect of that medication, some patients can become very sick when these two are combined. So that's an important one to watch for. The other one is warfarin, or Coumadin. So this is a fairly common medication. And what it does is it doesn't inhibit warfarin from breaking down, but it inhibits one of the breakdown products of warfarin from breaking down. So theoretically, it could make you more likely to bleed if these two medications are combined. However, this is one of those rare things, something where you need to monitor your INR probably a little bit closer as you're starting the entacapone, but nothing that means you can't be on these two medications alone or together. So the other dopamine extender is the MAOB inhibitors, and these are rasagiline, selegiline, or safinamide. So these medications have been shown to also decrease off time a little bit less than the entacapone, but still up to an hour a day. You may have more on time, and they're used mainly after you're already on the carbidopa-levodopa. Side effects with these: upset stomach, kind of muscle aches, headaches, joint stiffness, so watch for those. Early in the disease, if this is started as rasagiline is started as a monotherapy, sometimes it can idiosyncratically worsen the symptoms of Parkinson's disease. So they may have more stiffness and a more difficult time moving around. So just something to be aware of. And then selegiline is broken down into an amphetamine. So it is activating. So people who have a lot of fatigue with Parkinson's disease and they're wearing off, I'll try this medication, but it's important to know that you have to dose it during the day. So first thing in the morning and an early afternoon, nothing later, because otherwise you'll worsen insomnia. So this is the one where the interaction is probably most important. So MAOB inhibitors break down, or MAO-B breaks down levodopa. Now, there's an MAO-A that breaks down other neurotransmitters, okay? So at high doses of MAO-B inhibitors, you can also cause loss of breakdown of these other neurotransmitters. Other neurotransmitters like serotonin and norepinephrine, okay? So if you start to inhibit the breakdown of serotonin, you can get too much serotonin in the system. When you are also on a medication like an SSRI, so those are selective serotonin reuptake inhibitors, the whole purpose of that is to keep more serotonin in your brain. So if you have two different medications that are increasing serotonin, you can get into this life-threatening side effect called serotonin syndrome, okay? So this is a big and important thing to watch for when you are starting these medications. It's not that you can't be on the two in combination, but higher doses of both of them make you much more likely to have this life-threatening reaction. So when we, as the movement disorder specialists, are not adjusting medications for the mood and it's their psychiatrist or their primary physician, I will often reach out to them before I start this medication so that they are aware that they can't just increase the mood medication without letting me know because of this potential reaction. So finally, just to kind of wrap it up, we had that other category of medications that can help with Parkinson's disease symptoms. So this first one is amantadine, and amantadine was actually a drug that was approved for treatment of the flu back in the 1960s, and that's when they found that it was also effective for treating the symptoms of Parkinson's disease when given to patients who had the flu. So how does that work? Well, it has some anticholinergic effects, so it blocks acetylcholine, which kind of modulates how dopamine is used in the basal ganglia, so maybe that. There's also been some studies that show that it kind of enhances dopamine release and blocks its reuptake. So it's also probably propagating your own dopamine's work in the brain. But what I'm going to tell you is this is not a first-line treatment for our symptoms of Parkinson's disease because the effect is modest, okay? Where it has the best effect is in levodopa-induced dyskinesias in order to calm down the dyskinesias. So the dosing is different for immediate release versus the longer-acting formulas, which are new. Side effects of this medication, because it is an anticholinergic medication, confusion, difficulty concentrating, can cause or worsen hallucinations, can cause leg swelling, this abnormal rash on your legs, so it's just a discoloration of the skin. It's not itchy, it's not painful, but sometimes can be disconcerting to patients. And then trouble sleeping, because this medication can be activating for the regular release, and a loss of appetite. Interactions with this one, really you just have to be very aware of other anticholinergic medications that the patient may be on. So a lot of our patients have overactive bladder or urinary urgency and incontinence. So they have to run to get to the bathroom on time. So they're on a medication that can help them control that. Those are anticholinergic drugs, okay? So the combination of those two medications, of that medication with the amantadine can cause more confusion, more hallucinations. So more dry mouth, more dry eyes, important to watch for. And finally, the last one is another anticholinergic medication called Artane or trihexyphenidyl. This medication is helpful for the resting tremor in Parkinson's disease that doesn't always respond to levodopa. And it may help some of these other motor symptoms by modifying how dopamine is used within the basal ganglia. Side effects, like we talked about, dry eyes, dry mouth, confusion, constipation, urinary retention. So this is not a medication I actually use in patients who are older than 65 for these reasons, because they often have a lot of other medical comorbidities that make it very challenging to know, am I causing that side effect? Is that something from their diabetes? What's going on? And then the potential for confusion and hallucinations. And then yet again, if it's an anticholinergic, don't combine it with other anticholinergic drugs. Okay, so now we're going to get to the less dry portion of this talk. Apologize, we had to get through everything, power through everything in order to give you a basis. So what we're going to do is we're going to kind of go through the stages of Parkinson's disease and then kind of go through some case-by-case basis. So specifically focusing on those middle stages and later stages of Parkinson's disease, how do I adjust therapies in order to treat their symptoms. So many years before the onset of motor symptoms of Parkinson's disease, patients can experience non-motor symptoms of Parkinson's disease. So reenactment behaviors, that's punching, kicking, screaming, acting out your dreams when you sleep. They can have loss of smell or even just decreased smell. They can have chronic constipation and even mood changes, depression and anxiety being the most common. And then as the disease starts to manifest, so those are these motor symptoms, patients will have an asymmetric presentation, meaning one side of their body will be affected before the other. And that is with stiffness, slowness, or that resting tremor. And then that slowly progresses, and over about 3 years or so, it'll start to spread and go to and involve the other side of the body. Most people are diagnosed within that first 3-year window. But what I'm going to say, the caveat is, if you have a tremor, you're likely to be diagnosed earlier in that 3 years. If you don't, and you're just stiff and slow, it's easy to kind of throw that back onto old Arthur, or arthritis, and so people then can have the delay in their diagnosis. Typically, as we are in these early stages of the disease, when their symptoms become bothersome, we start them on treatment, and patients respond very well, and they feel almost like they are back to their normal self. And that response lasts. For some patients, that can last up to 5 years, and we call this the honeymoon period. But after that, then we enter these middle stages of the disease where the medications aren't as effective, and you get these motor fluctuations. So I go from having a great response to having no response, to have a great response to having no response, and they're constantly going on and off. Or their medications overshoot the target, and so they get these levodopa-induced dyskinesias, which I guess were demonstrated very nicely earlier. That is when we start to talk about non-medical options, so surgical treatment options for the patients with Parkinson's disease. Then that latter stages of the disease, so about 12 years on, is when the non-motor symptoms of Parkinson's disease start to progress. And we start to have more problems with motor features like freezing of gait, postural instability, and falls that are not responsive to treatments. So really, when we're talking about the medication managements and what we had, and all those medications we just went through in detail, we are really talking about how we target the symptoms early in the disease. And once we get to year 12, then it's kind of fine-tuning, sometimes even taking away drugs and managing these other non-motor symptoms. So when we talk about starting medications, since you are all now experts in medications of Parkinson's disease, carbidopa, levodopa, or Symptomatic is the best tolerated and most effective medication, so that is typically what we recommend starting first, no matter the age. Dopamine agonists have good evidence that they are also very effective, so that is a reasonable starting medication. And then we'll talk just briefly about MAOBs and using it as an initial treatment. So which is best? So I talked to you about those studies. So there are 3 different studies that look at a dopamine agonist compared to carbidopa, levodopa. And in all of those, these motor fluctuations and dyskinesias are delayed if you start with a dopamine agonist. But then we have all of these side effects. So in patients, I will counsel them as they're coming in, they're having motor problems, and we'll talk about all of these because a lot of our patients are very well educated and they are very scared about levodopa-induced dyskinesias. So I educate them about what is a dyskinesia, what does it mean, it's not toxic to the brain, and really just kind of let them know what is the evidence that's out there, and then let them help with the decision. But then if they choose a dopamine agonist, I make sure that I'm very clear about what we have to watch for each and every visit and what you have to let me know about so as to avoid any of these other side effects. So why not start with an MAOB inhibitor? So MAOB inhibitors have been shown to have mild symptomatic benefit in patients with Parkinson's disease early. There was even a couple studies that did show that rasagiline may be neuroprotective, so may change the course of Parkinson's disease. However, over time, as we've kind of looked at that study and we've learned more about how carbidopa, levodopa acts, we know that that is not likely the case. Unfortunately, we don't have any additional studies in order to help us really confirm that this is really disease modifying. So in my patients who come in, they're first diagnosed, I will talk to them about these studies. And I will tell them, we have these 2 studies that say that maybe the rasagiline might slow the rate of decline of your Parkinson's disease. Since your symptoms aren't bothersome, do you want to try it? And I will offer it like that. Since the medication is no longer just brand name, it's a little bit cheaper, and this is a little bit easier to get patients to try a medication. What my own experience has been is that the results are modest, okay? It's not gonna treat your tremor. It may make you feel like you can move around more easily. The studies have shown that there may be a help for people who have some depression. So in patients who are early and having problems kind of coping with their new diagnosis, this might be a good option for them. But generally, the comorbidities kind of limit this because, again, that interaction with the serotonin, the SSRIs and SNRIs. So from here, we're just gonna focus on these middle stages. So that was kind of your brief blurb about the beginning of Parkinson's disease. But now we want to talk about the other symptoms that occur and how these motor complications affect how we manage patients with Parkinson's disease. So Mr. P is a 65-year-old gentleman. He has a history of high blood pressure and Parkinson's disease for about 12 years now. He's currently taking Sinemet 2 tabs every 4 hours, so it's about 4, sometimes 5 times a day. And about 60 minutes before each dose, he will start to slow down. And as his motor symptoms will worsen to the point that he can't walk, and he has to take his this happens sometimes even before he has to take his next dose. So this kind of illustrates that motor fluctuations that we get in this middle stages of the disease. So this graph here in blue shows you what is the good period. So when that line is in that good period, patients have a good effect, they can move around, they can do everything they want to do. As the disease progresses from left to right, you see that some of these lines now overshoot that target. And so people are getting side effects because they have too much levodopa in their system. Or before their next dose, it kind of falls down into that pink level, which is under-medicated. So they start to fall off. So they go from this fluctuation of I'm on and I'm great, and then I have these extra wiggly movements to on, I'm great again, and then I fall off before my next dose. And this is kind of the progression of these motor fluctuations. So when we get into motor fluctuations, how do we treat that? Well, I had mentioned earlier, as the disease progresses, we need more levodopa or more frequent levodopa. So that's often the first thing we'll start with, is increasing the dose in order to get a longer response or putting the doses closer together. The other option is to change to a longer acting formula like the Rytary. Then you can consider adding extending agents or dopamine agonists. So dopamine agonists are not just useful when they're initial therapy, but they're also useful in extending the benefit of the levodopa. So dopamine agonists can be added, extending agents, COMT inhibitors, so entacapone with each dose of the levodopa, MAO-B inhibitors, or zonisamide and sulfonamide. These are a couple other ones we didn't touch on, but have a little bit different mechanism in addition to the MAO-B inhibitor. And then, as we fine-tune medications and they're still fluctuating from on, or they're only on with horrible dyskinesias, or off, and they have these unpredictable on and offs, that's when we start to talk about surgical treatment. So just briefly, zonisamide is a medication that is very similar to sulfonamide or Xadago, one of the other ones that I just mentioned, I threw onto the slide with the MAO-B inhibitors. They do have MAO-B inhibitor effect, that's that drug that extends the life of the levodopa. It also has an additional effect on the calcium channel blockers and glutamate release, which is not really clear how that helps our symptoms. What it really did was this study showed that this is about as effective as just a plain MAO-B inhibitor. So it doesn't add a whole lot more than those drugs. But if they can't be on some of the other extending agents, then this is a potential option for a patient with motor fluctuations. It is a seizure medication, so the biggest side effect of putting someone on this medication is that it makes them sleepy. Okay, so Mr. P was changed from his regular Sinemet to extended release Sinemet, or the Rytary, so his dosing went down from 4 to 5 times a day down to 3. Over time, so initially he did really good, and then over time he started having these times where his medications wouldn't work, or he'd abruptly turn off without warning. During these off periods, he couldn't move. His wife had to be there to help him sit down, otherwise he might fall. And then his doses of levodopa were adjusted. So he came back to his movement disorder specialist. We said, well, I can fix that. Increase the dose. I put the doses closer together. I changed formulas, but nothing was working, and he continued to have these disabling motor fluctuations. So there are now rescue medications that we can give our patients as they are in these middle stages of Parkinson's disease, feel themselves wearing off or wear off abruptly without any warning so that they can get moving again more quickly. So in the past, all we had was, well, I want you to hold a tab in your pocket and chew it, and then we'll get it into your system as fast as we could. Or people would carry around a water bottle with Levodopa that was dissolved into that. They'd shake it, and then they'd drink that, get it into their system a little faster. Now we have a couple other options. So the new one is inhaled levodopa or Ambrosia, and the other that's been around for a little bit now is apomorphine or Apokin, which is a dopamine agonist. So inhaled levodopa is the levodopa, just like in Symptomatic. It has 2 little pills. They're 42 milligram pills. You put them in this inhaler, so it snaps apart. You put in the pill. You click it together until it clicks and it punctures that pill, and then you inhale. And you have to inhale for 5 seconds, and then you have to do it again. Okay, so each of these 42 milligrams, the total together is 84 milligrams, and that's your dose, and that's about equivalent to getting a half a tab of the levodopa. Okay? Now, the studies were great. What they did was they compared them against placebo, and they showed that even after just 10 minutes after doing this inhaled therapy, they had a good improvement in their symptoms. And then the best improvement was all the way at 30 minutes, and then it kind of stayed. So what it allows us to do is if they can do the inhaling, and then they can sit there for a few minutes, then they're able to move enough that we could then give them their other pills and get their other pills getting in their system so that they don't wear off again. The problems with this are, remember I talked about sometimes these motor fluctuations can get to the point that you can't move. That can be an issue. So it's not too complex to be able to pull this apart, put the pill in, and then smack it together. But you really sometimes need a caregiver if you're really very disabled. So that's one of the limitations in doing this. For some of our patients, it may be too technical in the off state. Side effects with this are cough. It's an inhaled formula, so that's not surprising. Patients can get dizzy, headaches, have some nausea associated with this. So it's very similar symptoms to what we get with the levodopa. This was not tested in patients who were on MAOB inhibitors and shouldn't be used with that because it can worsen orthostatic hypotension. So after you inhale it, then it could make your blood pressure drop, okay? So that's the interaction we have to be aware of. So Apokin is the other rescue medication. So this is a sub-Q injection. It's got a little, you can see this whole kit here that you can put together with needles as well as the medication dose. Side effects of this are very similar to the other dopamine agonists that we already talked about, but they are more intense, okay? So we know that dopamine agonists have nausea and they have orthostatic hypotension. Just think, I'm giving you a punch of dopamine agonists. It's going to be more effective and it's going to have more side effects. So we have to pre-treat these patients with an anti-nausea pill before we can give them these injections or even titrate these injections. Over time, they can be titrated off of the anti-nausea pill, but it's a thing that limits us being able to just start it right away. The other thing is in order to start this, or in order to take this medication, you have to go through a trial period where we actually have to titrate it up to get it to the right dose. So that used to be very bothersome and cumbersome. You'd have to come into the office and sit there, and if the patient had a side effect and was vomiting, it just doesn't look good in the office. But now this can be done in the comfort of the home with a nurse that can come into the home in order to help with this titration. So it's a little bit easier to use this drug. So Mr. P was started on Ambrosia in addition to his Rytary, which seemed to help his unexpected off times, made him a little bit more functional throughout the day. Unfortunately, later that year he fell and had to be admitted to rehab. While he was there, he was unable to take his Ambrosia, and the timing of his Rytary was changed from his typical 7, 12, and 5 to 6 a.m., 2 p.m., and 10 p.m. His wife called the office distraught because she had been told that Mr. P may now need to transition to long-term care because he wasn't able to participate in therapy, because he wasn't getting his medication as prescribed. So this case clearly illustrates the importance of making sure medications are timed exactly as your physician has prescribed them. So best practices for managing medications when patients are admitted to the hospital, to a rehab facility, to a longer-term care facility is continuing the medications as they are prescribed by their physicians without substitutions if possible. So if they can't do something, like it's a brand new drug like the Ambrosia, and they just don't have the ability to do it, they don't have the staff who are trained to do this, you have to let your physician know so that your physician can come up with an alternate plan, whether it be chewing that levodopa or something else to help them with those abrupt offs. Remember that there are different doses and different formulas of the levodopa. It is tricky. All of those slides specifically put all of the doses on those slides to show you one pill is not like another, okay? Even in the best healthcare system, it's easy to make a mistake when you just look at the front. Each of these different drugs, whether it be CR, ER, they all have a different formula, they all have a different dose. So it's important to really very clearly know which one the patient is on in order to give them the right drug. And then timing is everything. So problems occur when patients miss medications. So I've given you a couple examples of that in that case the patient couldn't move. Other things, so if you can't move, you're more likely to fall, have problems swallowing, could aspirate, and then could also have this could also be so severe as to be life-threatening. So as the disease progresses, the rigidity within the axial portion makes it very difficult for some patients to roll over in bed. So if a patient gets rolled over, they wear off and their face is in the pillow, unfortunately that could be life-ending. So it is very, very, very important that these patients are given their medications as prescribed. It also causes worsening non-motor symptoms. So not only do you get stiffer and slower and your tremor come back as your symptoms wear off, a lot of patients will develop significant anxiety and panic attacks that can cause confusion and hallucinations as well. So these are all very important reasons why we try and keep medications on the right time. There is a danger to stopping these medications abruptly as well. So neuroleptic malignant syndrome can occur with acute withdrawal, and this is where patients become very, very stiff to the point that it causes muscle damage. They become febrile, tachycardic, and have autonomic dysfunction, which, if not supported properly, can lead to death. So it's very, very important that these patients get their medications and that they don't miss them. So unfortunately, we don't have good evidence about what happens when patients miss doses of medications in a long-term care facility or a rehab facility, but we do have some evidence about what happens when they're in the hospital setting. And that's shown that they can increase the complications that are associated with that hospitalization and increase length of stays in hospitalizations. So one retrospective study, and this was done in the UK in a surgical ward, actually showed that 71% of patients had a missed or late medication for their Parkinson's disease. And then 40% of them were actually given a drug that would worsen their Parkinson's disease, and complications occurred in half of these patients. And what they showed was that actually with the more doses of missed medications, the higher the rates of complications. A second study in Spain actually found that medication errors occurred in about a third of their patients, and this led to 4 days of increased hospital stay and also a higher mortality rate. So we can say, well, this doesn't happen to us in the US, but actually it does. So down in Florida, they also did a similar trial, and what they showed was theirs were about 30%, 25 to 30% of patients would miss their medications. Another 23% would get medications that could worsen their Parkinson's disease. And unfortunately, even us as neurologists made no difference on this rate. So even if we were consulted in the hospital on these patients, that didn't seem to make a difference. So it's not just a lack of specialists, it's a system issue. So timing is everything, and it's most important for the Symptomatic, okay? And it's most important that you identify some of these areas where it's easy to kind of get off. So when patients are admitted to the hospital or they're admitted to skilled facilities or long-term care, it's easy for us to just write TID, which means 3 times a day, or QID, which means 4 times a day. And that's not typically dosed at the times when patients take their Symptomatic. So you need to really be sure that I have doses, and I know my patient has always taken them at 7, 2, and 5. I need to make sure I've got it 7, 2, and 5, and that's how they're written. If doses are missed, they should be given as soon as you recognize that they are missed in order to help that patient transition back into the on period and to avoid any of these dangerous complications. Now, missing dopamine agonists, extending agents, and amantadine, also not great. but not nearly as pressing as the Sinemet. So these medications should be given as soon as it's recognized that they were missed, except for the extended release amantadines. Those need to just be skipped for the day and then gone on to the next day and take it. So we're just briefly going to skip through some of these because they're all there with some information about the different changes in the course of Parkinson's disease, but I want to actually get to the last two cases. And I know that you already had some talk about the falls and imbalance and freezing of gait and how to overcome these things. Okay. So Ms. K is an 82-year-old woman with a 15-year history of Parkinson's disease. She was seen in clinic due to increased falls. The falls only occur when she's transitioning to the standing position, but can occur even when she's standing still and has been standing still for a few minutes. She endorses lightheadedness and dizziness when she's standing and will often stumble into a wall, even though she won't fall to the ground. She had one episode of loss of consciousness since her last appointment. So this case illustrates the importance of asking additional information. When you say, okay, well, you're falling, yeah, I fall a couple times a week. Okay, there's many different things. Just like Brian pointed out last session, many different things that contribute to falls. As Parkinson's disease progresses, orthostatic hypotension becomes more prominent. Not just because the non-motor symptom of Parkinson's disease becomes more prominent, but also because they're on higher and higher doses of levodopa and dopamine agonists that contribute to this. So symptomatic orthostatic hypotension is defined as a fall in the systolic blood pressure, so the top number, by 20 points, or the diastolic number, so the bottom number, by 10 points when you go from a sitting or lying position to a standing position. And you need to check that at 3 minutes. So it's not just, I'm gonna have them stand up and check their blood pressure. You often have to wait because that blood pressure can continue to go down up to the 3 minutes. Patients may sometimes tell you that they're lightheaded and dizzy when they change positions. They may also just tell you, oh, I just kind of stumble when I change positions, or I have some pain in my shoulders, or you know, my legs, they're just shaky. So there's all kinds of ways that patients can describe this, but it's always important, if it always happens or tends to happen after a change of position, to always think about orthostatic hypotension and check the blood pressure. So the rates that I saw were actually somewhat higher than the rates that Brian pointed out in the last session, and up to 50% of patients can be affected by this. And unfortunately, this is a big risk factor for motor decline in our patients, as well as mortality, and it causes falls, which can lead them to fracture hips, and is one of the 2 leading causes of reason for placement in patients with Parkinson's disease. So important for us to recognize early, even before they get into these kind of issues. So whenever I have a patient who comes in and they're lightheaded and dizzy when they're changing positions, I'm always going to talk to them first about what can you do at home before I have to start another pill to add to your 25 that you're already taking. And that's first is to increase their water. And there's many reasons that patients will be adverse to increasing their water intake and their salt intake. The biggest one is that they have to urinate then all the time, okay? So just making sure that they're aware of why we're doing what we're doing. Having a bottle of water available, even one of those small little bottles, is also very important for when the symptoms come on acutely. They can drink that water right away, and it can increase their systolic blood pressure by 30 points. So even if they can't, we encourage them to drink throughout the day, but always at least have a bottle there in those emergent cases where they can't stand up because their blood pressure has dropped. But the recommendations are that they should be taking in at least 2 to 3 liters of water a day, which is astronomical. That is a lot of water, so I encourage them to carry around at least 6 bottles of water. If they can't do that, we start with 4 and we work our way up to write numbers on water bottles so they know where they're at for the day, to get a big water bottle that they know they only have to fill up 3 times, because sometimes 3 is easier than 6 for them to mentally kind of get their brains around. And then just come up with different tricks in order to help them remember. The other thing is salt. So And these patients, we're working with an elderly population who has been ingrained in them, salt is bad. And that's really important for when there's cardiovascular disease. Salt is bad. However, in these patients who have orthostatic hypotension, you can have all the fluid in your body that you want. You will pee it out if you don't have the salt in order to help you keep it in your system and keep it into your veins. So we encourage them to add salt. If they don't like salt, add salt tabs in the morning. Wearing compression stockings, abdominal binders can also be helpful. Abdominal binders are much less cumbersome for patients than the compression stockings, which can be very hard for an elderly person to put on themselves. Keeping the head of their bed elevated when they're sleeping is also very important for 2 reasons. So when your head of the bed is flat, in patients with Parkinson's disease who have orthostatic hypotension, they often also have supine hypertension, meaning their blood pressure raises when they lay down. So that high blood pressure at night increases the risk of strokes, of heart attacks. It also sends off a chemical in your brain that tells you, I gotta get up, I gotta pee, my blood pressure's too high. So by raising the head of the bed, it decreases those things. It allows you to not have to go to the bathroom so often overnight, keep more fluid in your system, but also protects your brain from strokes. And then if these things don't work, so we've primed the pump with the fluid and the salt, if that's not working, then the next step is to add a medication in order to help with this. First thing we do is always review that medication list and see, can we take one away instead of adding one? So taking away things like their antihypertensives with the help of their primary doctor or cardiologist, or even decreasing some of our Parkinson's disease medications. Like I said, dopamine agonists, big offender. Levodopa can also be a big offender, so you just have to see if we can tease it down a little bit to help with their symptoms. And then first line are the older agents. They're not specifically approved for patients with Parkinson's disease-related neurogenic orthostatic hypotension, but they have really good evidence in treating orthostatic hypotension. And so we'll typically start with fludrocortisone or midodrine. Then we have droxidopa, which has been approved for short-term use in patients with neurogenic orthostatic hypotension related to Parkinson's disease. All right, and then finally, Mr. N. Mr. N is a 75-year-old gentleman with a long-standing Parkinson's disease and mild dementia. So they presented to you for an urgent evaluation of increased confusion. Per his wife, he's become more tired over the last week. In the last couple of days, he has been more forgetful, making comments that don't make any sense, having hallucinations, and falling more frequently than usual. His wife denies any signs or symptoms of infection. However, he has had a couple more episodes of incontinence. Current medications include 2 tabs of Sinemet every 4 hours. He's also on entacapone with those, as well as amantadine. Your evaluation is notable for a little bit of a temperature, and it's tachycardic. He's inattentive, he doesn't answer questions that he should know and that you've asked him in previous evaluations, but he's just not correct this time. So you obtain a urinalysis thinking it's incontinence, he's got some symptoms of an infection, let's check for that. And what you know is that it's notable for a urinary tract infection. So you decide to start him on treatment. However, his wife calls the office 2 days later because he's still confused, and the hallucinations have become so severe that they're starting to affect him. So he's seeing people outside of the window and it's frightening him. He's up all hours of the night, so she can't get any sleep either. So we know that patients with Parkinson's disease, they can develop a simple infection, so a simple urine infection that might not affect someone who is younger, but it affects them very strongly, where it can make them confused, can make them hallucinate, can make their medications not work as well, so they might have increased tremors. So anytime that you see an abrupt change in one of your patients, and you're like, they're just not as sharp as they used to be yesterday, what's going on? And that seems to be continuing, and they seem to be getting worse. Always think about an infection that could be going on and having the doctor check that. Unfortunately, as we treat the infection, that delirium, so that confusion, that hallucination doesn't go away right away. I'd love that. But unfortunately, sometimes it will hang around for days to weeks, and unfortunately, in some cases where patients have had to be admitted for these infections, it can hang around months. So you decide to start an antipsychotic because these hallucinations are so bothersome and they're so frightening to the patient. Out of these that are listed here, which one will not worsen Parkinsonism. So out of these are all antipsychotics, all atypical antipsychotics, which are supposed to have less risk of causing Parkinsonism. However, we know from studies that olanzapine and risperidone act very much like typical antipsychotics and will worsen Parkinsonism. Aripiprazole is a newer atypical antipsychotic, again, purported to not cause worsening Parkinsonism. However, I see multiple cases of drug-induced Parkinsonism from this drug. Okay, so it's not quite as bad as olanzapine and risperidone, but will cause Parkinsonism. Quetiapine is the only medication on here that has not been shown to worsen Parkinsonism. So quetiapine, the other name for that is Seroquel. So when we talk about which medications we must avoid in these patients as the disease progresses, typical antipsychotics as well as most atypical antipsychotics we should avoid. The only ones that are safe are quetiapine or Seroquel, clozapine, or pimavanserin or Nuplazid is the other name for that one, okay? Anything else that is prescribed in order to calm down hallucinations could make those motor symptoms worse, that stiffness and slowness worse. The other things to be aware of are some of our patients will sometimes just go with a GI illness with nausea and vomiting. There are actually some drugs that are used to treat nausea and vomiting that can worsen Parkinsonism. So Reglan and Compazine or metoclopramide and prochlorperazine are important ones to avoid in this population. A lot of these other ones are not very common, and you probably would not see them in your patients. At the bottom, you'll see that some SSRIs, those are the medications for depression, have been shown to increase the risk of causing Parkinsonism, but this is very, very rare, and so this is not a contraindication. Okay, so you decide to start Seroquel. You start a very low dose and gradually increase at bedtime. Unfortunately, over the next month, he continues to have bothersome hallucinations and delusions. So you review the medication and decide it's time that we start to minimize his levodopa or one of his other medications in order to really try and work on these cognitive issues. Out of these medications, which one could you taper first? And this kind of brings home a key point that as the disease progresses, we often have to adjust which of these medications we use, and then based upon their side effect profile, ones that we know are going to cause more confusion and hallucinations. So in this case, amantadine is the most likely out of these to cause worsening confusion and hallucinations. So in a patient who is confused, hallucinating, not just from their Parkinson's disease, maybe it's just from an infection, you don't necessarily have to go right away into taking away the PD medications, but if it's prolonged, a lot of times we may have to start to decide to adjust those medications. The first step in treatment of these confusion is to know which medications to avoid and which ones to remove. So if patients are in a long-term care facility, they're on a lot of opiates for pain, consider trying to go to something like Tylenol that's not going to be as hallucinogenic. Or for severe agitation, the Seroquel is a great option to just kind of calm things down instead of something like a benzodiazepine like Ativan, Xanax, which can just make people more and more confused. So knowing alternative options. Add a safe atypical antipsychotic like we talked about. Quetiapine is always kind of our first line here with these, especially when you need it just on an as-needed basis. And then if needed, work with your movement disorder specialist or your neurologist in order to decide which of these other Parkinson's disease medications might we be able to get away with if we taper them off. So in summary, medication management in Parkinson's disease is very complex, from knowing all of the medications that are out there, when do we time them, how can we alternate, which ones interact with which ones. So a few key points to take home from this. If you are a patient or caregiver, take the medications as prescribed by your physician. So each patient is very individual and needs their doses at different times of the day, and that has been specifically titrated by your physician for those times of day. Okay, so it's important that you try and take them as prescribed. So put alarms on phones to remind you if you're always forgetting the 2 o'clock dose and then it gets too late in the day. Advocate for your loved ones. This is the biggest thing that you can do for your loved ones if they have to go into the hospital. Make sure you have an up-to-date medication list. Make sure that you talk to the physician or resident who is taking care of them so that they know specifically what times and that I need the medications to be given at these times and that the order has to be just for these times. That's very, very important and a way that you can advocate for your loved one. Providers. You should be aware that there are different doses, different formulations, and that these are not necessarily one-to-one, so you can't just substitute based upon what's available. Try to work with the pharmacy that's dispensing or the movement disorder specialist in order to adjust the dose for what is available. Prescribed medications should be time-based, so that's just when Mr. P takes them at 7, 12, and 5, not at TID dosing or QID dosing, and make sure medications are given on time to avoid those potentially life-threatening complications of the stiffness and slowness, aspiration risk, fall risk, or anxiety and panic attacks. Remember, general medical illnesses can cause worsening PD symptoms and confusion and hallucinations. Doesn't necessarily mean medications are necessarily needed. Be aware of what medications to avoid in patients with Parkinson's disease. And as the disease progresses, we do often need to adjust the medications that we give our patients with Parkinson's disease, but please do so with the guidance of the neurologist or the movement disorder specialist who is caring for the patient, as they're going to better be able to tell you what interactions there are and what the potential complications are of decreasing one drug versus the other. So thank you very much for your attention, and I'm happy to take any questions.
Thank you, Dr. Wyant. All right, here we go.
Do you specifically have in the written orders as far as the time-based information so that other healthcare professionals understand how important it is to
Yeah.
give it at that exact time?
Yes, it's very important. It's because it's harder to do. It's easier and it's automatic in most electronic systems in order to just say 3 times a day and then it automatically goes to what times a day. When you are doing time-based dosing, you have to put in a lot of times a different dose for every time of the day if it's an electronic system. So it can be cumbersome, and so I get it, why it's easier and why people will kind of default to that. But it is so very important to make sure that it is ordered specifically at the time and not with a TID or QID, because that is often going to be way too far apart for the doses. Yeah.
As far as missing a dose and then taking it as soon as you realize it, if your doses are typically 5 hours apart and you realize at 4th hour, oh my goodness, I missed my middle dose, say, and you take it, should you wait the 5 hours until you take the next one?
That's a great question. So if you remember because your symptoms are wearing off, you should take it as soon as you remember. But you don't necessarily need to take that next dose an hour later. Right. You can just kind of reset for the rest of the day, okay? And this is kind of at home. I know that that is not as easy to do when you are in a rehab facility or a long-term care facility, but when you're at home, you have a little bit of leeway. If you're that close to the next dose, just take it early and then just try and adjust the remainder of the doses throughout the day.
Any other questions? Okay, well, thank you very much, Dr. Wyant. We appreciate it.
Thank you.
Great talk, great talk.